As we know, fracture of shaft or tibia are unique in that the bone is subcutaneous with depleted muscular cover, and the consequent decreased vascularity leads to complications like delayed bone union, wound complications such as dehiscence and infection. Intramedullary nailing is the most popular, widely used method for treatment of tibial shaft fractures. Intramedullary nailing involves minimal surgical dissection, allowing preservation of blood supply by not disrupting the soft tissue around the fracture. Several reviews articles have addressed the use of reamed and unreamed intramedullary nailing for the treatment of open and closed tibial shaft fractures. However, the search methodology and criteria for including studies may bias the result. To date, there are still no published systematic reviews and meta-analysis comparing the use of reamed and unreamed intramedullary nail for open and closed tibial fractures. The purpose of this study was to compare functional and radiological outcome in the shaft tibia fractures treated with interlock nail versus interlock with injecting reamed autologous materials. A randomized prospective comparative study was carried out in the Department of Orthopaedics over a period from July 2019 to May 2022 with proper informed consent. 100 patients were studied and divided by simple random sampling. 50 were placed in group 1, which was IMIL nailing plus reaming and injecting the autologous cell. Other 50 were placed in group 2, which was only IMIL nailing plus reaming. Inclusion criteria were skeletally mature patients giving valid consent, shaft tibia fracture, it's a closed fracture, and extra-articular fracture. Exclusion criteria is pathological fracture, compound fractures, intra-articular fractures. All patient included in study was followed up in examination, on examination or at 6 weeks, 8 weeks, 10 weeks, 12 weeks, 16 weeks, 24 weeks, and 48 weeks after surgery. So the technique is the regular steps of tibia intramedullary nailing was performed in sequential reaming. The reamed material from the first 3 or 4 reaming was found to be of viscous and thick. The amount of reamed material from the first ream was about 8 to 10 ml. The reamed material was collected in a sterile syringe and percutaneously injected at the fracture site under C-arm. So these are the images. First image, we do the reaming. Then we collect the material and put it in a syringe, and then we percutaneously inject the material on the fracture site with the help of C-arm. So the results, the average result of union in IMIL plus reaming plus the injection was 14.13 plus minus 3.5 weeks versus 18 weeks in IMIL and only reaming. 38 patients in the injection autologous cell group had fibular fracture, and 40 in the reaming group had associated fibular fractures. 33 of the 38 fibula fracture in injection autologous cell were mid-shaft fibula fractures, and 36 out of 40 fibula fracture, approximately 1/3 fibula fractures. So after the result, the radiological deformity, one patient in IMIL plus reaming plus injection had the deformity, and 2 patients in IMIL plus reaming. One patient had varus deformity, and 2 patients in only IMIL and reaming had valgus and varus both. So there's post-op complications like restriction of ankle movement.
You need to stick to the time.
Yes, sir. So the functional outcome were assessed by John and World criteria, which was excellent for IMIL plus interlogous cell compared to only IMIL and reaming. This is the same discussion, sir. So conclusion is the union time was better with IMIL plus reaming plus the injection, which took lesser time. It was found that the autologous cell was faster union time earlier. It had earlier weight bearing and better overall functional outcome as compared to only IMIL and reaming. On study, 80% success rate is shown in accelerated bone healing in tibial shaft fracture with the reamed material. So, thank you, sir.